Good evening. Welcome to the third in our series of webinars sponsored by the Aesthetic Authority, Dermatology. Our first two webinars were what do we do now and how do we get back in opening our practice. And so I think tonight's webinar is particularly timely because we're going to be talking about the medical legal aspects of opening our practice back up and for really the next several months of existing in a new norm. It's a norm that none of us ever anticipated, but all of us are going to have to deal with. So I called up some of my buddies that are lawyers and regularly appear at various meetings that I helped put together. And the first person I called was Alex Tiersch, who is my co-moderator tonight. Alex has been on any number of meetings that we've done. Alex is the executive director of the American Medical Spa Association. Some people call it AmSpa. He's also a member of an outstanding law firm that does have some specialization in healthcare law, I believe, and that's Bird Adato. And so we're honored to have Brad Adato from that group is one of Alex's partners and is one of the senior members of that group. We're also honored to have another person in that group who joined recently, and that's Dr. Jeff Siegel. Many of us know Dr. Siegel as having a company that we've seen around for a long period of time. I've probably known him for over 20 years. His beard has gotten gray during that period of time. But I've known him really since I was doing the Newport Beach meetings. And Jeff has a company called Medical Justice, as I said, that helps defend doctors. And Jeff's an attorney, just like Dr. Adato, just like Mr. Adato and Mr. Tiersch. But Jeff also has the distinction of being a neurosurgeon. And so that makes him particularly important to us tonight. Dr. Abel Torres is a physician in Florida who not only is a JD as well, an attorney by training, but is also an outstanding and well-known dermatologist. And Dr. Tony Geroulis is online with us. We weren't able to get his picture up there, but as Tony said, that doesn't cost us anything, and it could be a good thing. No, I'm just kidding, Tony. But Tony is an outstanding facial plastic surgeon at the University of Chicago. He's been a friend of mine for many years, and he too is a JD and is a lawyer. And then finally, last but certainly not least by any means, is one of the outstanding facial plastic surgeons really in the world. And he's been a mentor of mine in a way, pseudo mentor, and has been a friend and close associate for well over 30 years. And that's Dr. Galen McCullough from Gulf Shores, Alabama. Galen is not an attorney. So Galen, it's you and I against all these attorneys tonight, but we're going to ask them some really good questions and they're going to ask us some really good questions. So we're excited to get started. I'm going to be fielding questions. So if you've got questions, I think there's a format that you can send them to me. And I know we're going to have a ton of questions tonight. And so I'm real excited about that. We've got a long agenda, lots of bullet points to cover. Alex Tiersch and I put these together. And there were really things that, the way I usually do things are things that concern me with my own practice. Those are the types of questions that I want to ask Alex and his associates and get input from the physicians who are lawyers and also Dr. McCullough as well. So let's get started. Alex, you want to take the floor at this point?
Sure. Hey, thanks to all of you for joining us. This is a great honor. I have to say I'm a little bit intimidated. I've only got a JD, which appears to be insufficient with this group. We've got multiple people who got a lot more letters behind their name than I do. So, but thank you all for joining, and thank you, Dr. Waldman, for having me. This is obviously something that all of us have been thinking about, both from a legal perspective. I know Brad, I think practice has been fielding a ton of these questions, and I know everybody in your own practices you've been dealing with these for some time, and I have a sinking suspicion they're only going to get worse as far as the number of questions we get. So Dr. Waldman, please let me know when we get questions that come in. I'm sure we're going to be busy with them. I think probably the best way...
Alex, I'm going to say one thing, but in introductions, I guarantee you, while we're having this webinar, and you can confirm this for me, there are 100 webinars going on around the country with attorneys talking about the same thing, but they're looking at it from a different perspective than we are. And so we're going to try to weigh in tonight on some of the things that they're talking about and maybe how we can avoid them.
Yeah, I don't think we have a plaintiff's attorney on which should be maybe our next one. We'll have to kidnap one and force him or her to be on the webinar with us. But you're absolutely right. I know for certain that there are the plaintiff's bar and the trial bars, they're gung ho, ready to go in various ways with respect to this pandemic. And really, there's no real good way to start this conversation other than to just get it going and start diving into some of the questions. I think I would love to start off with Brad Adato. You are in practice and you're dealing with these questions all the time. And I think just I'm sure we all, including those on the panel, would just love to hear, kind of generally speaking, when you see these practices start to reopen, the surgical centers, the med spas, dermatology clinics all over, what are some of the landmines that you're worried about? What are some of the things that keep you up at night with these practices, and that we need to start worrying about kind of from a general perspective?
Yeah, absolutely. I mean, the first thing is, unfortunately, there's no golden compass that's going to tell us exactly the first step that you're supposed to take. And so a lot of our clients, when they're asking us, what's the first thing I need to be considering? What's the thing I need to be worrying about? And I always just go back to safety first, right? The safety of your team, your staff, the safety of your patients, the safety of your facility, and of course, the safety of yourself. And what's happening is, because people are being open, we're seeing that people are rushing in to get their patients in, and they're not collecting themselves and thinking about, okay, what kind of homework should I have done already? Because if you haven't done this already, you're letting the patients run through the front door, you're obviously going to expose yourself, allowing COVID-19 to walk through the front door with you. And so what we've been preaching right now is take it slow, be patient, understand that slow is good right now, and making sure you have all your processes in place. And I know you've talked about in other webinars, but that's the thing that keeps us up, is that we're getting the phone calls of people who are opening the doors and then coming back to us afterwards and saying, okay, what processes do I need to put in place? And as well, what kind of training have you done for this, or what have you done for that? And so those are the landmines that you're rushing to get the people from and I get it, because everybody wants to have the income coming through. But you have to be careful, because you don't want to close yourself down because you expose your staff or your facility to COVID-19. So that's the landmines I'm thinking off top of my head.
Absolutely. And when you mention these processes, though, I mean, there's so many to think of. But one of the things that gets me kind of nervous when I start thinking about this is it's all the unknowns, right? There's so many things that we don't know. We're all very worried about liability, worried about getting sued. When it comes to types of processes, are there one or two protocols or one or two things that you're advising your clients that they need to get in place right away? Is it like a specific protocol? Is it a release, a consent, something like that? What's the number one thing you're advising people about? Educating your staff before they come to the front door of what the expectations are. So if the staff doesn't understand what you're supposed to be doing, as far as obviously most doctors' offices, based on a lot of things that we're looking at, the threshold that you typically is obviously wearing a mask and having great hand hygiene. But that's just having the mask and having good hand hygiene reports is not going to be sufficient in a medical facility. So one of the things we talk about is, do you have posters and videos, in which if you go online, there's a ton of different things that you can find as far as posters and videos of teaching people how to have good hand hygiene. I know it sounds silly, but that's important. And the donning and doffing of your PPE. Again, a lot of your staff, if they're not on the surgical side, aren't used to wearing PPE. And so to them, understanding how to take it off and put it on correctly is something they need to learn.
And so those kind of the policies as far as your staff is what they need to know before they come to the front door. And then the cleaning of the facilities. That is the second area, because again, if you have to have how do you clean the handles? How do you clean the rooms? What are the processes? What cleaning materials are you using? Those are the kind of things that, again, going from a processing perspective, that you should be looking at.
Dr. Siegel, I feel kind of weird calling you Dr. Siegel. I've always called you Jeff because you're with the firm. I'm curious. I'd like to get the opinions of the panel here too, because one of the things, and I'm going to jump around a little bit because this just popped in my head. I think it's important. One of the things that we've talked about from a liability perspective, or from opening up, that we advise clients on is testing. Right? Do you test patients before they come in the door? Do you test patients prior to surgery? One of the questions I got today that kind of threw me for a bit of a loop was if you decide to test somebody, and I know some states like Dr. Waldman, I think Kentucky's one of them, actually requires tests before surgery. If you end up testing a patient before surgery, and that patient tests positive, are you now under, or what's your duty to actually care for that patient with respect to COVID? And I wonder if you could kind of talk about that. And I know I'm jumping around a bit, but I think testing is an important question here. Jeff, what do you think about that?
Okay, so let me start by stating, assume everyone that comes to your office, once you've screened them for clinical symptoms in the past, assume they're all pre-symptomatic, that they've just assumed they've been exposed, okay? That way you will do the two things that you must remember, which is wear a mask, wash your hands. Wear a mask, wash your hands, wear a mask, wash your hands. If you remember nothing else, remember that you will be safer than if you just ignore it. So my brother, ophthalmologist in Houston, he opened up his practice about 2 weeks ago, wearing a mask. The patient was wearing a mask. He referred the patient to a retina person, gets a call 9 days later stating that his patient was in the emergency room having just been diagnosed with COVID. And he's freaking out. I said, were you wearing a mask? Yes. Was the patient wearing a mask? Yes. She was pre-symptomatic at the time. He's okay. There's nothing he really needs to worry about at that point. Now the patient's in the emergency room. The baton has been passed over. So just assume everyone is pre-symptomatic. In terms of testing, every state treats it differently. I think the best screen that you can do is calling the patients beforehand and identify, have they had symptoms, have they had COVID? And there's a checklist the CDC puts out. It's pretty easy just to commit it to paper and just ask the patient on the telephone, XYZ. If it looks like they recently have had symptoms, they don't come to your office until they've been free of symptoms for a specific period of time. Again, all that is in the checklist. Some states do require testing. What does that mean? It means that if it tests positive, I assume through a PCR test, then they get shuttled to a practice that can deal with that. It's not necessarily your responsibility. And for the most part, most of the people are going to be staying home and doing nothing. They're going to be in isolation and told not to even come to an office. But unless you're that patient's primary care doctor, and most people listening on this webinar are not going to be the doctor, you just conclude you've got a positive test, and I want you to follow up with your doctor for advice. And then once you've done that, you've discharged your duty. I think you want to be a nice person. You probably should call them afterwards and see how they did. It's helpful to close the loop and get an understanding of what worked, what didn't work, and so on. But I think in terms of mandating testing, it may be more trouble than it's worth. Unless you are forced to do it by law, I think you may be opening up a can of worms above and beyond just doing the clinical checklist on the telephone, as well as assuming that everyone is pre-symptomatic.
Good advice. Dr. McCullough, I would love to hear your view. I mean, I'm a lawyer, so my head is spinning about how I can, defend people from lawsuits or sue people. As someone, who's been in practice, what are, and I'm curious, and I'd like to hear from Dr. Torres too about this too. What are you thinking about as far as types of liability and how are you looking to protect yourself from litigation as it comes out? I know that Alabama has passed some laws with respect to COVID, which I think is going to help. But what are you doing to prepare your practice for what we all think might be at some point a lawsuit or two coming down the pipe?
We had a meeting with my entire staff before we ever opened up again. And I told them and reminded them of something that I've often said throughout my entire career, is that every contact with a patient, the first time that the patient calls your office for a consultation, you should begin to prepare the file for a lawsuit. And you write down everything, you document everything, and we reminded people that we will face some claims, perhaps, with this COVID. So we do everything that we can do. We call them and talk to them ahead of time. We do require testing for all of our patients, and I prefer the serology test. I prefer the IgM test is what we try to do, because that tells the patient or tells us whether or not the patient has an active infection. And we require that prior to performing any surgery. And we've had a couple of uncomfortable days, I guess you would say, because it's a 72-hour test. And it took a while, and we did not, for example, the patient I operated on today, we didn't get the report until early this morning. And I was not going to operate on the patient. If I did not get the report, I was not going to proceed with it. So we're doing that, and then we do have the posters and framed around and on our countertops to remind everybody, if you have been ill, please tell us. If you've been out of the country, please tell us, and those kinds of things that are the standard. And if so, then we ask them to please reschedule their appointment and to return at a later date. So we all wear our masks, and we do the hand sanitizing. And I like to do that so that the patient actually sees you doing it. I walk in the room with my mask on, and we have sanitizers the minute you walk in the room, and I squirt it in my hands, and I have them seeing me do that. I want the patients to see that we're doing everything that we can, exercising what has oftentimes been called the abundance of precaution. And so, we also don't do the handshaking and the hugging and that sort of thing that is classical or typical in my practice, and we try to do that. And so it's just a matter of being conscious of all of these things and trying to do the right thing. I don't know that we can ever totally protect ourselves against litigation, but I think it's making an effort. And the governor's mandate, or I'm sorry, the order that the governor of Alabama signed, and it says that unless you have, let me read that just a little bit, because it's a great legal term. And it says here that it provides immunity for treatment that results from, was negatively affected by, but including, but not limited to, the contraction of alleged exposure to the COVID-19 on the premises of a healthcare provider, and claims from the provider's efforts to prevent or delay the spread of COVID-19. And here's the important thing: unless proven by clear, convincing evidence that the provider acted with wanton, reckless, willful, or intentional misconduct. Mm-hmm. And so I think that's language that unless you do something really foolish and you just exercise the abundance of caution and make an effort, I don't know what else we can do.
I agree. I agree. There's only so much that can be done. One thing though that we've done, I've seen a bunch of these bouncing around that I would love to get. I'm not sure if Dr. Torres is still with us. From what I'm seeing, the screen went blank. Are you still there, Dr. Torres? It's like he's in deep space. So let's go to Dr. Jaroulis then, and I would love to hear from the rest of you as well. We've seen a lot of these COVID releases, right? That folks are having, lawyers are drafting, and before patients can get treated, they come in and it has a whole bunch of language about, you could get COVID, you could potentially die, you could do all this other stuff, and that, you know, there are pages and pages of legal language. Dr. Drulis, are you in favor of using those? Have you used them in your own practice? And what are, if not, are you worried about some of this litigation and liability coming down the pipe?
Well, in Illinois, which is a very litigious state,
yes, it is.
probably tops in the country, next to New York, maybe. Our governor mandated, just like Galen has, that our patients have to have tested COVID negative before we can operate on them. And my entire staff are required to be tested, and everybody that is there is COVID negative. If anybody turns out to be COVID positive, I would do exactly like you heard, refer them to their family doctor, document it all, and check on them every week or so, and document the fact that you're following up and checking on them, so that you cannot be accused of any kind of abandonment. The other thing, obviously, when we schedule or talk to a patient, prior patients that were scheduled, and now the new ones via Zoom, we go through a history, just like you've heard, and we cover everything. But when the patients that morning, we have a whole protocol. The patients cannot come in our office. They are told what time to be outside in their car. And then somebody goes outside, escorts them into the office. That person is in gown, gloves, and mask. They are brought into the office. They are kept 8 feet away from everybody. And then we go over the consent form. Then they're allowed to sign it. And then we go over the special consent form, which covers a lot of this pros and cons of COVID and how it can do everything in terms of killing you. And they acknowledge it all. They acknowledge, and we already have a printed form that shows they were COVID negative, or else we don't even let them in the office. We have to have that form before they come in the office. And then we practice exactly what you're hearing. I will see the patient, and I will have a gown on and gloves and hat and mask. And then I will take the pictures, have the patient, I do facial plastics, so they'll take off their mask. I'll do some photos. I will then mark the patient, and then anesthesia will come in dressed the same way, and they will prep them. And then we proceed to the operating room, at which point I will take off that gown, and we will put on sterile operating room paraphernalia, gloves, gown, new hat, and new mask. Post-op, the patient then recovers, and then we call their loved one who should be waiting in the waiting room. We alert them we're coming out with the patient, and then we escort the patient out. I then follow up with the patient with FaceTime and document it so that I have their healing process that night. And when I can do it, like for an upper lid or upper and lower lids, I will check them via FaceTime the next day, as opposed to having them come in the office. And then we'll see them a week later for suture removal. On the facelift patient, then I will follow them the same way. And then we will see them the next day, however, physically, and change their bandage. But the protocol will remain the same, and they will see me with gloves on and gown on and mask on and cap on at all times. Obviously, there's no touching. There's no, the old way of taking care of your patient right now is not going to happen. I think that's all you can actually do to protect yourself. The patient sees how careful you are, just as Galen was saying. And when the patient sees how careful you are, they feel safe. Now, there's no way to tell, because you see, the problem with the COVID test, as I see it, is they're negative at that moment in time.
Right.
And we talk to them about keeping themselves isolated in quarantine until surgery. And they tell us they do. But there's no way to know if they really abide by that. And there is no test we can give them that morning of surgery yet to clear them. So until those tests make themselves available, you know, we're stuck where we are.
Yeah.
So that's how we're handling it. And I agree with Galen. Whatever the governor of your state proclaims, make a copy of it, because sometimes they change these things, and you need to be able to produce the dated copy of the legal ruling that you were following by the governor's office at that time. Because otherwise, they may change it on you, and you will not be following the exact rule. So I would say once a week, document what the governor says, and keep a file, and keep yourself up to date like that.
Alex, just in passing, there was a great, and everyone that's on the webinar should probably take a look at this as they're opening their office. I thought that there was a great article, or it's really more than an article. It's 61 pages long in the current edition of Facial Plastic Surgery and Aesthetic Medicine, which is a publication put out by the American Academy of Facial Plastic Surgery. But really, it was a compendium of a number of different sources, whether it was ASAPS and the College of Surgeons, and it was something put together by the Skin Better Institute, which was Jonah Shackney's group. Jonah used to be in the industry with a company called Medicis, the founder of that. Many of us remember Jonah from that company, but it's the best thing that I've seen and the most comprehensive guidelines to opening your practice. And really, I think it's going to be used as a reference source for so many people looking at that from both sides of the fence. And I would recommend that everyone really kind of take a look at that. We sort of guided our practice. We had many of these guidelines or many of these protocols in place because we looked at the same documents. But when people come into our practice, we do everything from limiting it to the patient with no children and no guests coming with the patient into the office to limit the number of people. We don't leave people in the reception area at this point. We have 8 or 9 rooms, whether they're treatment rooms or consult rooms, that we can take a patient immediately to those rooms. We now book by the room rather than by the patient. So we want to make sure that we have those rooms booked. And also we want to make sure that we clean those rooms carefully. We're wearing masks. We haven't started doing injections yet. The governor isn't giving us the go-ahead until May 25th, but we're prepared for that as well with N95 masks and with covering over scrubs. And we're having everybody change when they come into the office and change when they leave the office at the end of the day, talking about our personnel. But we get a text from the patient in the car. We welcome them in our lobby. We put them on our elevator after a questionnaire to make sure that it's a short questionnaire, that we have actually kind of a receptionist now down in our lobby, which is on the first floor where our surgery is. And they'll send people up the elevator if they pass that questionnaire. Have you been sick? That kind of thing. We'll take their temperature. We'll give them a mask. And everybody comes in the office. We'll wipe off the elevator buttons, wipe off the rails to show them that we're cleaning everything up. Only one person on our elevator at a time. They then come into the reception area where they're greeted very friendly, and nicely by one of our nurses who will walk them to a room. And then we'll treat them whatever we're going to do in the room. A lot of our consults are still being done in a virtual manner or a telephone. We're doing telephone consults. We're actually finding, and I mentioned this the other day, we're finding that we actually have the patients like that, and we're actually having a higher rate of acceptance or conversion, if you will, using that technique. It's been pretty interesting, and we've been pretty busy with that. Our phones are as busy as they've ever been, if not a little bit busier. A lot of that's adjusting schedules, but we're showing the patients, what we do, and we've all signed on to this. And who appreciates it most is, I think, our staff, because a lot of this is about protecting our staff, and we haven't talked about that. But there are really 2 forms of liability. There's employee liability, workplace liability, and then there's liability on the patients, for the patient side. So it's not just malpractice. There's other things going on here, and we have to take the lead role. And at least in our practice, we worked 2 weeks before opening. We were already working on this. And I would encourage all of you who have yet to open your practice, spend a lot of time on protocols, make sure they're written, make sure that we've sent it out to our patients. We're not marketing right now, but we're letting our patients know that we're opening up with the following precautions. So we sent all our patients a letter, e-blast, letting them know that we're trying to do things the right way, and anything they feel is restrictive is only because we're trying to do it the right way. We're sorry they can't bring their children. We're sorry they can't bring a guest, a spouse, a friend, boyfriend, girlfriend, but it's just that we're trying to social distance everyone the way that the governor is requiring, and I think it's quite appropriate what they are requiring. So that's what we're doing in our practice, and you know, we've got at some point, Alex, we've got a ton of questions that people are asking. So when you get to that point, just come back to me, and you know, and we'll start going through these questions that people are asking about all this type of thing.
Yeah, let's get those in 1 second. Actually, I think it's probably good for us to get to those because that's what people are asking. I do think you made a good point that we should probably address kind of right away, which is the duty that employers have to their employees. And I think, you know, we talked a little bit about some of these state laws, Illinois, Alabama, where the governors are issuing orders trying to protect businesses. One thing that we're going to have to address, though, are things like OSHA and ADA, because those are federal laws and they're federal regulations. And so we're still going to have to deal with that. And I guess, Brad, since you're the practicing attorney, Brad Adato on the panel, what should folks be thinking about when it comes to their employees and potential liability? I mean, are we going to require everyone to test all their employees, and what can we do in order to protect ourselves? Because to me, that's almost a bigger risk than patients is what's going to happen with your employees. What are your thoughts on that? And then I think we should.
Absolutely. I mean, I agree with that. Your employees is your number one risk. And anytime someone's upset with you, it tends to be your employee before they even come to your patients. OSHA, which is the Occupational Safety and Health Administration, has received over 3,000 complaints since January because it's such an uptick, and this is well off the chart. That's not including what's going on at the state level with complaints on their own levels. And so, yes, your employees, the risk of exposure as an owner is coming from your employees first. And so going back to, I think, a lot of the different things that the gentlemen were talking about throughout this process is, what have you put in place to educate your employees and to protect them? And I think the most important thing all that you can think of is, and you can hear about it and see about it, where restaurants and other facilities are not allowing the employees to protect themselves for whatever reason, they're going to report you, number one, so that's going to slow you down. Number two, it is terrible press, right? If you're a medical facility that is not providing the proper equipment. And number three, it's against the law when it comes to OSHA. OSHA will come in and fine you and or shut you down. You have a requirement under these rules to provide the necessary equipment. And again, OSHA applies to all different spectrums, but the necessary equipment to free the person from hazards of that. So again, going back to typical doctor's office, that's why, when you keep talking about hand washing and masks, some of them are doing gloves. Others are obviously, depending on what they're using, they might be wearing goggles. Again, depending on the procedure they're doing. And then obviously once you go into the OR, everything changes as far as the increase of that they need. And then on the ADA side, the ADA piece, this is an interesting area where you typically have to protect your employees about releasing information. But because of the pandemic going on right now, you are allowed to do certain things and ask questions that you're not normally allowed to do, which means you are allowed to ask your employees, are you suffering from one of these, fevers, chills, sore throat, lack of taste, a whole bunch of things that normally you can't ask. And you are allowed to test your employees. Right now, testing them via, you can, not extreme, but you can test them via temperature with the, forehead and test them The catch, of course, is whatever you learn from that, you can't publish it. So if you find out someone's running a fever, you're allowed to then send that person home through a quarantine process that hopefully you have in your process, but you can't explain that to anyone else in the staff. And I know it's difficult, right? Because you have to protect the rest of the staff. But at the same time, the ADA says you have to comply in protecting those individuals. So you're fighting all these different rules and regulations simultaneously, one being OSHA and one being the ADA.
Dr. Waldman, I do think we should get to some questions because we've already been going for almost 40 minutes. One point I want to make just real quick after what Brad said is that under the Americans with Disabilities Act, ADA, one thing to watch out for is if one of your employees mentions that they have some sort of a pre-existing condition that might impact how their risk under COVID, that there may be a duty to provide, like if they want to work from home or something like that, if they've got asthma or something that gives them a little bit of a heightened risk, the ADA may require some action on your part to at least try to accommodate them. I just want to make sure that folks knew that. And then I think we should go to some questions.
All right, let me start with a question for Jeff Siegel. Jeff, I've done an abdominoplasty, and 4 days after the abdominoplasty, my patient contracted a COVID infection, diagnosed as positive. What responsibility at that point? Obviously, that could be a significant thing. So, what responsibility at that point do I have in following the patient? Can I refer the patient out for treatment? What are my responsibilities and or liabilities at that point?
Okay, so the first question would be, did you have the patient sign the COVID consent form? And there they just acknowledge the obvious, that COVID is in the background, it's a pandemic, et cetera. So you want them to take ownership of that and actually affirmatively stick their name to a document. The other reason to doing that is that in every practice, there will be 1 or 2 patients a year that will not sign a reasonable document like that. They'll either want to redline it, edit it, or say they won't sign it. You probably don't want to operate on that patient because they're telling you up front they won't even acknowledge the obvious. So I'm assuming you have all that in place. The next question is, well, what happened with this patient? Did the patient get it from your practice? Did they get it while they were recovering at home? And the truth is, we don't know. We just call them pre-symptomatic until they became symptomatic. But once they become symptomatic, the first question is, well, there are 2 parallel questions. The first question will relate to your office. Did you follow all of the guidelines to protect you and everyone else in your office so your office doesn't have to shut down? If you're wearing a mask, and wash your hands, wear a mask, wash your hands, wear a mask, wash your hands. If you're doing all of that, your office will still be up and running. You will not have to shut down. And these are guidelines. This is exactly what my brother's practice went through when he was freaking out. But because he and in fact, everyone here, I want to give a shout out to all the clinicians here. These are what I call best practices. They are excellent practices. This isn't just clear and convincing evidence. This is going beyond a shadow of a doubt to do everything to not only be safe, but also to be perceived as safe. And that's not, I can tell you right now, not everyone in the field is practicing like that, but everything I've heard tonight from the clinicians on the panel, these are really the types of things you want to aspire to. But the final question would be, what is your obligation? You want to make sure that the patient has a proper handoff to someone that is used to taking care of COVID. There are people now who are entirely comfortable taking care of COVID. They've been doing it. They've been fielding phone calls. They understand the treatment protocols, et cetera. Just hand the baton off. You want to make sure that you quickly get your patient into these people's hands because on occasion, these patients will decompensate very rapidly. They're called the happy hypoxics. They seem like they're doing okay, then all of a sudden they decompensate. But you want to make sure that the right people are able to take care of these people. Even though you took care of them surgically, this is a team effort at this point. Once you find out that they have tested positive, you want to make sure that a person who is entirely comfortable taking care of that is the captain of the ship.
let's go to Alex Tierce. This question's for you. In my practice, if one of my employees gets sick and tests positive for COVID, what happens in our practice? We can't quarantine everyone in the practice for 14 days. What do we do then if somebody becomes obviously sick that we've been working very closely around?
Yeah, it's a good question. You need to, number one, obviously the first thing, and while this is obvious, you need to quickly have a process in place where you can get that patient or the employee to actually be home. So you need to have your eyes and ears open so that you can actually recognize that people have symptoms. You got to have protocols in place. One thing that I think is important is make sure that your team knows what the rules of the road are. If they test positive, they need to stay home. And then I think at that point, what you need to be doing is making sure that everyone else gets tested to see if anyone else has been sick. If they haven't been, then really you've satisfied your duty. I mean, to me, where the problems are going to come, and I'm putting on my sleazy lawyer hat right now, thinking about how I would be able to go after somebody. It's going to be if they didn't follow some of the basic protocols, and they didn't test, or they didn't do a test, they didn't issue proper PPE. They didn't follow the exact protocols that were in their books when they were trying to bring somebody in. And because that's what a plaintiff's attorney is going to do, is they're going to take your protocols, they're going to take the governor's orders, they're going to go through every single step of it and see if you ticked off that box. And if you didn't, they're going to say, well, that is clear and convincing evidence that you weren't doing what you were supposed to be doing. So, if that happens, you've got to take it seriously. Get that employee to stay home. I would personally recommend testing anyone that employee's been in contact with, and until you know that your employees that are going to be dealing with patients are in the clear, you need to keep them away from people, because I guess that's another perfect example of a potential clear and convincing action, where that I would argue is that if you know somebody is one of your employees has tested positive, and you don't do everything necessary to keep the rest of your employees safe, you're now not only violating your duty to your employees, but potentially anyone that those employees come in contact with. These are the kinds of things that if you open up the can of worms, like your head starts to spin, because there's just so many different ways it can go. It could go in.
I saw your eyes there. Do you have anything that you would add to what Alex said about an employee who tests positive, who's been right in the heart of your practice, treating patients? What's the responsibility that I have at that point to both my patients and to the employees beyond anything? Alex, I think you're absolutely on the money with that, with testing for sure. I think everybody would have to be tested. But Brad Adato, anything more?
No, I think Alex is right. I mean, obviously, as Jeff said, if you already have certain protocols in place, you've been certain people weren't exposed to this individual because they may have been always 6 feet apart. Go back to, and I completely agree. One of the things we always talk about, form and substance. If you have beautifully written protocols and you're not following them at all, a plaintiff's attorney will use that. The government will use that against you, because as beautiful as the protocol can be written, if you're not following them, they're actually worthless. And then going back to, if you've already had certain things in place where this person was isolated in the way they were interacting with them, you definitely want to have that person removed, wait for at least obviously the 14 days plus 3, depending on your state, for that person to be able to come back into your facility. Don't forget, again, going back to the ADA or HIPAA, you have to be very careful about releasing information either on the patient side or on the individual who may be self-quarantining. The other piece is, depending on who the individual is, you may be able to let them self-quarantine via telecommuting, so they can go back to your billing manager maybe, or another person who typically does not interact with the patients, and you're uncertain. Just have them leave the facility. Again, keep the minimum amount of people that you need at your office at a given time. So again, if you had some person that did show up with COVID-19, all your back office individuals who could be working from home are working from home, so they're not exposed and your office can continue. And then clearly whatever room or the individual was working in, you want to obviously have a good team come in and clean it all our clients, we're recommending that they have outside, if they're not doing themselves on a daily basis, having a deep clean at the end of every single day. And that would be another situation where if that person was in one particular office or one particular exam room, a deep cleaning of that room.
We're getting a lot of questions about consent forms, and I can tell people that the ASPS, American Society of Plastic Surgeons, I believe has a fairly good consent form for surgery that they put out. And it's also in the appendix of that article that I mentioned, the 61-page article in Facial Plastic Surgery and Aesthetic Medicine this month. And again, you could probably write to Better Skin, the Better Skin Institute. I think it's in California. They're the ones that put the grant out for that article, and probably they can be a resource for that. And if you can't find it anywhere else, then you can email me and at srwaldman@AOL, and we can help you find that article. It was great. It was mandatory reading for everybody in my office. It produced the consent form that we use in the lobby, the history form that we use in the lobby. We added this consent form to every one of our specific operative consents, where it talks about if you get a COVID infection, that it's possible, that we're in the middle of a pandemic, and that it's possible, and that you acknowledge that a COVID infection can be life-threatening, and that you're taking a risk by having a surgical procedure. I don't know that it has anything specific in there that surgery lowers immunity or anything like that, but we do have that discussion with patients in our practice, particularly the bigger procedures. So anybody, we had a lot of questions about consent forms. I think it's very important to have a specific thing in your consent form for any surgical procedure. Maybe even it needs to be added to your injection consent forms. We have consent forms for every single injectable material that we inject, and it's specific for each one. And so we're going to add the COVID part to that once we're able to start doing those procedures again. So I don't know if that answers all the different things that we've gotten for the consent forms. There was a question, Galen McCullough, how do we get our employees tested? Some states still require symptoms before testing, which is really, I feel like testing is increasing, and this is a new disease, and I think everybody's doing as well as they can to develop new tests. I think the FDA released a lot of tests prematurely, probably, but they had to do it. We were in the middle of a crisis. Some of these tests are really no more than 60 or 70% reliable because they really haven't been scrutinized for very long. But Galen, in Alabama, is there a problem getting tests? And again, the questionnaire, the person asked the question said that some states still require symptoms before testing.
We don't. We don't require symptoms in Alabama. I had all of my staff, including the people that are going to stay with the patient after surgery. Everyone was tested. And we decided to do the IgM test, the antibody test. I think it's more reliable, frankly, than a swab. There are too many things, in my opinion, this is just my opinion, there are too many things that can happen with a swab from the time it's headed toward the patient until the time it gets in a container. And, the ability of that person doing the testing to do it correctly. And I think that the serology test is much more specific. So we had everybody tested at that time, and that's what we're doing with our patients. And we didn't have any problem. I believe, I'm not trying to plug any particular lab, but at that time we went to LabCorp. And one of the other good things about that we found out is that they would accept an insurance plan and not require us to purchase the test until after the test was performed. Then the patient paid for it. And so we did not charge any of our staff, but the patients pay for their own testing. It's just simply added to their surgical fee. And I will tell you that to follow up with another comment that was made earlier, we've not had any backlash from that. Our patients seem to be very proud and pleased that we are proceeding with the testing, because many of them want to know. And this brings up another question that I would like to hear the others address. We've had people from the community calling my clinic and asking if we would do testing. And I decided not to do it because I thought it would open up a lot of traffic coming into our clinic, and that we really are only reserving that for our patients and our staff at this point in time.
Also on questions, by the way, if you have any questions about the documents or the consent forms, I think the Aesthetic Authority will have a lot of those documents, and we'll give them some of them. So be sure to reach out to the Aesthetic Authority website, and actually aestheticauth@gmail.com will get you the answer to a lot of those questions. Again, aestheticauth@gmail.com. Here's a question for Dr. Geroulis. How much space does my staff need to stay away from each other? Our office is not big enough to put staff in separate rooms while also being at a distance from patients. Do I have to have a more limited staff, or is it expected that staff will in fact be closer to each other than 6 feet?
Well, I think you have to explain to the staff that that's your reasoning, that you want them to stay 6 feet apart, and then let them sort of work it out, but make it your proclamation that you want to see them 6 feet apart, and document it, and have them all sign the protocol so that they've all admitted that they've got the protocol and they understand it. Now, in a confined space, we all know that if they have gloves on and masks on and so forth, it seems to me that even if they're closer, as long as they're not sneezing or coughing, then I don't think personally it's a huge issue because they've all been tested. But I still would, on paper, have them acknowledge that your proclamation is they need to stay 6 feet apart. If someone's passing in the hall, they need to go into a room and let them pass and then come out, and so forth and so on.
Or Alex, should you have employees sign a form which states that they're taking appropriate precautions, but the risk of COVID cannot be eliminated in the workplace?
Honestly, to me, that is probably a worthless document. I mean, I hate to say that. I mean, you have a duty to your employees under OSHA and under ADA and things like that. So having them sign that might make you feel better. I don't think it's going to do really a whole lot liability-wise. I mean, you have obligations under OSHA and as an employer to be providing a safe work environment, and simply having them say that they might get it is not necessarily going to protect you any more than anything else. To me, that's, I mean, I understand why we would want to do that. I understand the urge, but to me, the bigger thing is making sure that you have the proper protocols in place, making sure that you have it, that your team is trained. They understand exactly what's going on, that you've taken all the orders seriously. I mean, and then as Brad said, actually following the protocols that are put in place. So I don't think that's necessary. We've had clients ask for that, and I think that I'm not going to object to it if they want it. I think they need to be honest about what the impact's going to be. One thing before you move off of me is I'm curious, when we were talking with the last question about what you do if one of your employees actually has it, and we talked about your duties. I'm curious if anyone's heard, is there an obligation to contact patients who maybe have been in contact with that person? If an employee or a patient is coming in contact and say, one of our employees has contracted it, is there any obligation to do that, or should we do that? I'm not sure there's a legal obligation. I think you got to watch out for things like HIPAA and other things. But nevertheless, I mean, if you know that one of your patients, let's say it's a nurse or someone who's been in direct contact with a patient, has contracted it, that's also where a sleazy plaintiff's attorney is going to say, now you knew this person was in contact with a patient who might have a compromised immune system after surgery, and you didn't bother to tell them that they had COVID.
This directly in terms of CDC guidelines, when my brother called me freaking out because his patient did indeed have a positive. Now, we flipped it a little bit. You're talking about staff versus patient, but the calculus is the same. it really boils down to, is it possible the patient was exposed or the staff was exposed, or were they protected? So I know I sound like a broken record here, but if everybody was wearing a mask and you're washing your hands, you have followed the guidelines, doing everything you possibly can. You have done precisely what you're supposed to do. You don't have to shut the practice down. You don't need to do tracing, at least in this country. You don't need to do tracing because you've done the proper thing. You've done what you can do to minimize the likelihood that someone will contract it, particularly when they're in the pre-symptomatic state. I mean, if you think about it, how is this any I mean, it's different than patients showing up in a hospital. We don't shut the hospital down. It's because some people in the hospital are COVID positive. I mean, ultimately, we're following best practices. And let me contrast that with a physician who was taking care of the girlfriend of a relative of mine. They called me the other day and said, "This sounds kind of crazy." I said, "Well, what do you mean?" He said, "Well, I went in just to get routine care, and I was wearing a mask, but the doctor was not wearing a mask. So this person asked the doctor, 'Don't you think you should be wearing a mask?' He says, 'No, I don't really need to wear a mask because I've got a great immune system.'" Now, he hadn't had COVID, but I mean, what kind of message does that send to the patient? Now, the patient was wearing her own mask. Everything's probably okay. But if everybody's wearing a mask, washing their hands, you don't need to get into a mess. If any of his patients, this doctor's patients, got COVID, I think it'd be indefensible. I do think that you would meet that threshold for clear and convincing evidence of someone who was likely reckless when it takes almost no effort to wear a mask. Wear a mask, wash your hands. Did I answer your question? I may have dodged it.
No, this is a similar question. I'm gonna turn this over to Dr. McCullough in a way. But what if you have an employee who comes back to work and you furloughed that employee, and the employee just says, "I'm just not. I have a great fear that of working in an environment where I could catch this virus, and I'm not comfortable really being in any type of workplace at this point where people are coming in and we don't know whether they could be infected or not. I'm not comfortable in that environment." What's your answer to that employee? And then I want to bounce it over to Brad Adato to talk about employee issues there, and I'm going to ask him a similar question. So, Galen?
Randy, I'll answer that question, but as I've been listening here to all of this and thinking through this, I think, first of all, we just have to exercise reason and logic and good judgment. I don't know that we can develop a piece of paper that's going to outline every single thing that we need to do. But based upon my knowledge of the legal system, that the standard of care is based upon what a reasonable surgeon would do under the same circumstances. And I think that as long as we are doing reasonable things and exercising the abundance of caution and all of the little things that we've talked about here, then I feel very comfortable about that. But now, if I had a client, if I had a staff person that told me they were uncomfortable, I would give them an opportunity. I would furlough them. I would tell them, fine, you don't have to come to work. We'll find something perhaps for you to work at home. But if that doesn't work, then you let me know when you feel comfortable coming back. And I think you would be at great risk to try to force a person, employee, or anybody that said they were uncomfortable to force them into that situation. I don't think that any jury or any judge would think that's the actions of a reasonable physician.
Well, right, Galen. Here's a question. I'm a PA and work for a physician where we are just starting to, in a state where they're just starting to have lots of COVID cases out west. Currently, I'm able to do telemedicine from home. However, I'll be returning to work soon, the end of the month. Currently, no staff is, wearing PPE at this point. And when I return, I have requested to wear a face shield and at least a surgical mask. I've expressed my concerns. I'm not sure what to do from here, as I feel it's our responsibility to protect first our patients and myself? What liabilities do I leave myself open to if someone contracts COVID and I am wearing PPE and no one else in the office is? I think I know the answer to that, but Brad Adato, just very quickly, do you want to respond to that question?
Yeah, absolutely. I mean, number one, the employer does have an obligation on OSHA to supply them with their equipment. I definitely think they're well outside if they're in the medical field right now. I completely concur. The standard of care is something that you have to abide by. So if you, as any practitioner, whether you're a nurse practitioner, PA, or physician, I agree that you should be wearing the proper gear depending on the procedure. Again, at the very minimum, mask, face shield or goggles, depending on what type of procedures you're rendering. And if you don't feel comfortable, obviously working with the employer, unfortunately, it may be you need to find another place to work. Your exposure goes back to, yes, of course, that patient can name anyone. But unfortunately, a patient, depending on your state, can sue any individual they want. The limitation of what you did to limit their exposure is what you'd use in your defense. But I would be any practitioner that's out there that's not thinking about putting on gloves and masks at the very minimum as you're treating a patient. I believe you're well outside the standard of care. And if you've got in front of your medical board or nursing board, depending on who you are, they can consider you a threat to public health. And if you're considered a threat to public health, they can revoke your license, suspend you immediately. So I do not take that lightly at all. And then I definitely think at this time, listen to what every single great practitioner just said as far as what best practices are. Every one of y'all had great ideas of what you do to protect your team first, which then helps protect their patients. And if you're not thinking that way and you're not applying it, you're going to expose yourself, your team, and you're going to be shut down faster, either by OSHA or by your potential boards.
For Tony Geroulis again, and it really has to do with testing. Do you pass the charge for testing onto your patients where you require mandatory pre-op COVID testing, or does your practice absorb that?
No, we have the patient pay it, but it's been covered so far by all the insurances, so it hasn't been an issue. If a patient raised it as an issue, then I would pay for it.
Very good.
Simple as that.
And the other question was an interesting question here, Alex. We did get a question from someone about contacting patients that someone worked on a few days earlier. And I think the consensus is that, and I don't know that we've got a full consensus yet on that. Galen, if one of your nurses went home, was called in sick the next day and told you that it's one of your surgical nurses and that she had come down with the infection, would you begin to call some of the patients that you had recently done surgery on to be sure that they were okay? Or even in your clinic, your injection nurse gets sick and she's injected 10 people, in the previous 2 or 3 days. Would you feel obligated to contact all of those patients and let them know that she had gotten sick and to watch for symptoms? Or would you just kind of, let it go?
I would not let it go. You're asking me on the spur of the moment. I would think, what's the right thing to do? And I think the right thing to do would be to call those patients and say, are you okay? Just checking on you to make sure everything's all right. Any fever, any loss of taste, or any coughing, or anything of that sort, any symptoms whatsoever. And if they said, no, I'm fine, then I think I would say, okay, we're just checking on you to make sure. And I don't know that I would go ahead at that point in time. This is me thinking off the cuff. I don't know that I would go ahead and tell them at that point that I had an employee that had come down positive. I think that I would urge them to contact me if at the first sign of any of the symptoms that they might have of COVID. I don't believe that I would tell them at that point. And some others may disagree with me, but I don't know that there's any reason to frighten those people at this point. I'd be happy to, or be anxious to hear what some of the others, particularly some of the attorneys on the call, might recommend for that.
Is there, to Dr. Geroulis, is there any type of patient that you would be afraid to operate on with the COVID virus out there? Would you be afraid to operate on somebody that was immunocompromised at this point? Or is there any type of concern that you would have where you would change your pattern of who you operate on?
Well, yeah, I think it's pretty simple. I mean, if they have any kind of contributory compromise to their immune system, I would explain to them that the risks are too high right now and that we should put this elective surgery on the back burner. I would then suggest that they see their internist, who I would contact, and document the fact that because of this situation, I think it's too risky for them. I also would use age as a factor, depending upon if they were over the age of, let's say, 60, and they had any kind of respiratory illnesses or they had a history of pneumonias, then I would back off. I think the risks are too great.
Okay. Is there, I guess this could go to Jeff Siegel, but there was a question, it's a reasonable question. Is any mask acceptable? We're seeing all sorts of different masks, K95s, N95s, three-ply masks. There's probably 10 or 15 masks that are out there that we can go and buy. Everybody's selling masks these days. It's become the new trade industry. Are there different masks for different areas and different things that we're doing? And if so, tell me your thoughts on just that. That's one of the, we've had that question 4 times tonight.
Yeah, no, it's a great question, actually. The main purpose of a mask for most circumstances is to remind you or to keep you from sticking your fingers in your mouth. And I swear to you, that's exactly the main purpose. It's a way to avoid hand-to-mouth transmission of virus. So a cloth mask, surgical mask, N95 mask will all do that. Now, once you get into aerosol-generating procedures, where there's intubation, where the patient actually does have COVID or has been exposed to it, you do want an N95 respirator or mask. So that's when things change, when someone is either A, quite sick and you're around them, or you're going to be doing a procedure on someone where there's intubation. If you're in a dentist's office and there's a drill going and things are going flying all over the place, that's an aerosol generating procedure. So in those types of circumstances, an N95 mask would be the bare minimum that you would need for that. But in general, in real life, just doing a facial injection, for example, and someone who is not symptomatic, you can use a surgical mask. And it makes it a little easier to talk through a surgical mask compared to an N95 respirator mask.
Very good. That was a great explanation. I totally agree. I think that there's a different type of protection that goes on in surgery versus the clinic. However, I think if you're probably injecting people, and at least in the state of Kentucky, they require us to use dental precautions when we're injecting around the mouth, particularly the lips, and now we're and around the nose. So we're now into the territory where the virus does hide out, and I think that aerosolization there can be a possibility. So I think in Kentucky, we're, at least in our practice, we're probably going to be using N95 masks if we're injecting the perioral region on someone, and we are using it in any of the facial surgeries downstairs. I do have a question for, and I'm not sure. It's an interesting question. But I'm going to stay with you, Jeff, on this one. What about plume? Using Bovies and CO2 laser and things like that. Is there any particular liability that we would have with plume in this COVID environment?
Yeah, I would say I've been following this every day, getting as much information as I possibly can. And I can tell you right now, that's the first time I've ever heard that brought up. So I don't know the answer to it. I think protect your eyes, protect your mouth. I'm going to take an educated guess because the coronavirus is a wimpy virus. It doesn't take much to destroy it. It's got a lipid bilayer. It's easy to use soap and water to get rid of it. And heat also apparently destroys it pretty quickly. So if the bovie is doing its job and generating some heat, there's a high likelihood that that is not the greatest risk of the procedure. But the truth is, I don't know that anybody really knows. I think all you can do is try and protect your airway, protect your eyes at the same time, and you're likely not to have a problem. I do know surgeries have clearly been going on since COVID began, but the other thing that's kind of interesting is that healthcare providers seem to be at somewhat higher risk compared to the general population. Most people think it's because of just the large amount of COVID that they've been exposed to, higher concentrations in the sickest patients in the hospital. But I can't say I know with certainty that plume plays a role more than just the intubation and the aerosolization during the coughing and everything else that goes on with either intubation or extubation.
Quick follow-up, Alex. Do you have to have written documentation from staff that they want to work in the office and that they haven't been pushed into it or threatened in any way with losing their job, I assume?
Right. My goodness. Again, I think it's one of those things where it probably is not worth the time to be doing that, provided you are operating with the duty you have to your employees in mind, right? I mean, you have a duty to your employees to provide a safe environment under OSHA. Having them, sign off on certain things, in some ways is I suppose reason. I'm trying to think of, like what my best answer to that to a client would be, and I don't really think it's necessary. I mean, you have that duty anyway. Your duty to your employees is there as part of your employer. I think the other thing that I want to point out here, and I think Brad had mentioned this earlier, this is not only there's not only a legal obligation here, but there also is a PR issue here, in that all of this is being viewed through the rubric of this pandemic. And if one of your employees gets sick, if one of your patients gets sick, or if you don't, let's say you have a nurse who's treating several patients and she gets sick and you don't inform your patients, I'm not saying you should or you shouldn't, how this all looks from the outside is going to matter, whether it's fair or unfair. Perception is reality in this case. So, I mean, having all of your employees sign a document that says that you feel fine working here. To me, it's you're almost setting yourself up to have someone claim that you're not providing a good environment, and you're forcing your employees to sign this. So I'm not sure that I would do that, but it's an interesting question. Let me noodle that for a little bit.
There was somebody asked a question: will this video or this webinar be available? In a few days, it will be available on both the Aesthetic Authority website and on the Global Aesthetics Conference website, by the way, which is gaconference.com. So you'll be able to see it on there. There was a question about how often are you testing your staff? We're really not testing our staff because you would have to test them every single day. I don't see that testing your staff now and thinking that has any validity 2 weeks from now would be something that I'd really want to do with. Now, if you're in a practice, and this one is for Brad Adato again, and I have a great question here. How do you recommend dealing if you're in a practice and say one of several surgeons or doctors or dermatologists, whatever in the practice, just refuses to follow many of the protocols that we've been dealing with, and you're either an employee or another physician in that practice? How do you deal with that?
Well, it's hard for you to be the one that's dealing with it, but obviously, depending on, this is what I think one of the things that people keep talking about is what's required for them to sign one of the things that every group will have is that you've read these protocols, you agreed that you will follow these protocols, and there's something that needs to be signed off, whether that's the handbook or protocol. So everyone keeps talking about these signatures. So going back to your question, every single employee, including your physician employee, should have signed off that they agree to follow these protocols. And if there's a violation of the protocols, go to your policies as to who you're supposed to report to. So again, if it's a person that you report to management, and management at that point should be taking care of it. This goes back to the form and substance that we talked about from the very beginning. Because if you're not following these rules, and again, if you're just quote unquote, these are the rules, but you're not enforcing it, and then you have an outbreak, it doesn't matter how beautiful your rules are. They're actually, as Alex alluded to, they'll use those rules against you. And so if the physicians refuse to wear their mask or follow the protocols, there's an exposure for that practice and on the same liabilities we just talked about, whether or not it's OSHA or the medical boards or your state or local agencies, depending on what state you are. So each step of the way, again, I mean, what I love about this panel with the physicians, you've all established what should be the standard of care of best practices. And if you're a practice that's not following that, you're outside the scope of what would be considered the standard of care in your community. And I think you definitely are exposed, and you definitely should report it through whatever your policies are that allow you to report those to whatever the physicians are, your upper management.
Yeah, and I'd say if you're a physician working in a practice and something, is going on that you don't like, then I think you have to get all the physicians together and talk about it, and maybe even get a legal opinion from your corporate counsel or the person that deals with human resource law or whatever that you've got associated with your practice. We have some things. Another question: what specifically do you put in the patient chart? Telling them, and I'm going to just answer that. You put everything in the chart, because if it's not in the chart, that means you didn't ask it. So at least in my mind, I think that on every surgical patient, I think you have to address the fact that you talk to them about potential infections after surgery, and that you talk to them, that we're in the middle of a pandemic, and that risk have probably gone up just a little bit, but that you are doing everything you can to mitigate those risks, and I think that they'll appreciate that. So I think the more that you discuss this with people, probably the better off you are. And I doubt that anybody on the anybody on the panel would differ from that. I'm going to ask kind of a funky question. I'm going to start with, I'll start with you, Brad, since you're on the screen. What will TV attorney ads be telling our patients in probably about 3 months as they relate to the COVID virus and their experiences?
Obviously, there'll be a lot of discussions about whether or not you were exposed by your providers or your employers. I think employers, more than even the physicians, as to what did your employer do to protect you is what they'll be talking about, because OSHA is such an easy example. There's a lot of information now that's out there telling you what you should be doing at the very minimum. Many states have already released. I know here I'm in Texas have said this is the minimum requirements that we will require. So those TV ads will be pretty easy for them to run. And it's going to be all about, as Jeff said, hand hygiene and mask. And if you're not following those protocols and you're open, that's what they'll be talking about.
What do you imagine some of these TV ads might look like in a few months?
It's did you get COVID at work? Something like that, like it's not difficult to imagine how these claims are going to go. And I think, whether it's unfair or fair, we can argue about that all day long. It's going to happen. And I think I really like what Dr. McCullough said, is that a lot of this just comes down to what's the right thing to do from a human perspective, right? What's a reasonable thing that you should do under the circumstances? I get a little nutty when we start talking about all this stuff, because it gives lawyers a bad name, and I know the lawyers are going to be out there, fishing for claims. But it's the reality. I think what you need to, the most important thing that I think Brad said is form and substance. Have these protocols, but but make sure they're followed. If you do what the CDC is recommending, what your state is recommending, if you implement those policies and procedures, if you're washing your hand and you're following that to the best of your abilities, generally speaking, you're going to be okay. Now I say that and watch, we're all going to get sued. So.
All right, I'm gonna. We've got other questions, but I think a lot of these can be answered offline, and we'll try to answer as many of those. But some of them we've covered already. Just some wrap-up thoughts from the panel, and we'll just kind of go through, and we'll start with Tony Geroulis. We're back at work, fortunately. Most of us are back at work, or we're pretty close to being back at work. Anecdotally, I know we've started doing some surgery, starting with smaller cases, and we're not running the extreme load that we could because we're in Kentucky. We're sort of mandated to start slowly at a quarter capacity, and then a half capacity, and then full capacity. So we're trying to follow those guidelines. So I think we're all fortunate in that we're starting to get back to work. Tony Geroulis, what fears do you have going forward? Where do you think that the potential landmines still exist out there that we need to be concerned about, and any advice that you can give to practitioners out there from both a legal point of view and a medical point of view? And then I'll go to everybody on the panel and kind of ask them that same question. So be thinking about that answer. But I'll start with you, Dr. Geroulis.
All right. I think our biggest concern, the patients are well informed between all the news action and so forth, and having the additional consent form in there and talking about COVID and having them go get a test, that's fine. And I'm not looking to them to be the big problem. I think the big potential problem is our staff. And that's the group that can really come back and bite us for a lot of and sundry reasons. And that's why every time we are in the office, one nurse is in charge of taking everybody's temperature and logging it in on the login sheet. And then she's also there to ask them how they feel, et cetera, and to restate, if you're not feeling well, turn around and go home. I think documenting that reinforces the fact that we're trying to protect you. And I think that will be the best thing we can do. That's it.
All right. The same question to Brad Adato.
I mean, all your practices, y'all are in the business of treating healthy patients, and you want to remain that way. And the best way to remain treating with healthy patients is making sure you keep going back to safety first, which I think what I started with, which again is the safety of your team, because I agree that's your biggest exposure, the safety of patients, safety of your facility, and the safety of yourself. If you can, going back to Jeff's, there's just one takeaway: safety first. You do that, I think you'll be safe across the board, and you'll be able to sleep better at night, knowing that you won't be stepping on those landmines, especially when it comes to the exposures that you would have otherwise.
Alex Tiersch, your comment.
I think that's exactly right. I mean, the only thing I would add, I suppose, is to take it slow and be conservative. There's absolutely no reason to rush into this. This has had so many turns and twists, and it's going to have more, right? There's going to be spikes in your air. Who knows what's going to happen in 6 weeks from now. So there's no reason to rush this. I know we're all anxious to get going, but just take it slow, safety first, and then educate team and patients.
That's beautifully spoken, because that's exactly what we've tried to emphasize. I think this is like a marathon. We're in the first mile or two or three maybe, but we want to be able to finish the race. We don't want to use up all of our energy on that front end. So if we're careful on the front end, I think we'll be rewarded at the end of the race with lots of cheers and patients that believe that we do it the right way. And ultimately, our reputations are everything that we have. Dr. Siegel, your thoughts on that question. And I also want to pose it with another little trick question here. And this is a little tricky. So there was a question that was just written in. Are you saying avoid patients older than 60 or 70 for elective or aesthetic procedures because they might be higher risk for the virus? So that's an interesting comment there. Should we be operating first on the younger patients? Should we be putting the older patients at extreme risk? Take that one and run with it a little bit.
Randy, you absolutely read my mind. That's where I was going even before you asked the question. So everybody who has been in practice for more than 1 year, you go back to the fundamental basics. Most of the people who take care of elective practice, patient selection. You do not have to operate on everyone. And the more seasoned you are in practice, you realize that there are some patients you probably shouldn't operate on. Now, the thing about COVID is that we're going to coexist with this virus until therapeutics and vaccine come online. We're going to have to learn how to live with it. And we do know, I think, that the majority of people who get COVID recover. So that's the good news. The bad news is that there are clear comorbidities. The comorbidities are age, hypertension, whether treated or not, and obesity. And these are people that you do see in practice. And I would argue that these people are more vulnerable. And if you operate on a 75-year-old obese patient with hypertension, whether controlled or not, and even if they're medically cleared and they get COVID and are in the hospital for 1 month, that's not a good way to start. So I would take your time. This is a marathon. We ultimately will have therapeutics and vaccine at some point. We'll have therapeutics probably before a vaccine. I mean, even now we've got a likely convalescent serum, which will be useful in terms of mitigating the problems. But I don't think you need to start with a 75-year-old patient who's obese with hypertension. I would start with a younger patient. That's my personal take on it.
Which is kind of what our philosophy has been from the very start, even when we started writing these protocols. And so, Dr. McCullough, where do you think the issues will be going forward? The top two issues that you think that we're going to face, because certainly this battle is not over with this virus. We're going to have, I hope it's over by the end of summer, but there's certainly no assurance of that. And in your mind, is there a possibility at all that we might face a second wave of this thing and be forced to shut down again in the middle of winter? I mean, what are we facing here?
Randy, there's so many things that we don't know about this virus. The truth that we heard a month ago is not necessarily the truth that we're hearing today. And I think that we're still dealing with a moving target. We don't really know exactly what we're dealing with. Frankly, I don't know who to believe, because there are questions about some of our more authoritative health industry and health organizations where their information may not be as valid and truthful as we thought it was at one time. And it leaves all of us really in a quandary. And so I think we just have to proceed with our eyes and ears open and just do what I said earlier, always try to do the right thing, because we don't know exactly what we're dealing with. Yet we may very well have a second wave of this coming up. We may have a third wave, and we hear about how this virus mutates. And we may be dealing with a different virus in 3 to 6 months than the vaccine that's being developed right now. And so the vaccine that we have in 6 months or so may not even be the vaccine for that mutation. We really don't know what we're dealing with. And I think that we just have to do the very best that we can do on a daily basis. There are a few things that we've heard here tonight, a few things that are standard: frequent hand washing, disinfectant, masks, distancing to a certain point, being wise, don't do foolish things, take good care of your patients, the same thing you've been doing all along, and exercise an abundance of caution. And I don't know that we know much more than that at this point, quite frankly.
That, and I would add in that there was a question if a patient's mask has been removed for numbing, photos, and procedures around the mouth and nose. And we talked about that earlier. I think that we can learn from our dental colleagues. They've had masks and and goggles on for a long time. When we've gone in there, you feel like you're walking into a battle when you open your mouth and they're coming at you. But I think that we now have to adopt some of those same principles and be particularly careful when we're working around the nose and mouth. And those of us that do primarily rhinoplasty, or lots of rhinoplasties in our practice, to me, at least, those are people that I want a negative test on, ideally within 24 hours and at the most 48 hours. And we're trying to encourage our patients to really stay away from anyone that they could come in contact with that might have the virus after they test. And so it's real important to protect our staff, in that type of situation. Anybody else, I'm going to open it up right now for any final thoughts from anybody on the panel before we wrap it up, and then I'm going to say a final word. So back to the beginning, we'll start with Alex. Any final thoughts or words before we wrap it up tonight?
No, I don't think so. I think the advice that we've gotten has been great. I think there was some very sage and thoughtful advice from Dr. McCullough, who's been doing this for longer than most of us. So I don't think so. I think this is a marathon. It's not a sprint. Let's make sure that we are taking this very, very seriously. I think we need to give it the due attention that it deserves. But we'll get through this like we got through, and we're in this together, right? We're all doing this together. That's the one thing I think everyone needs to remember, that there's, we're all dealing with this, and we can all lean on each other for questions and things like that. So this is a great panel, by the way.
I agree. And you know what? It's the old thing. At this point, don't do anything for money. Don't let money be the thing that dictates what you do, because when you do, that's when you may step over that line. And remember that at the end of this whole thing, the people that will still be standing tall are the people that just did the right thing and the safe thing for their patients. And I still believe in that principle. And I think what you were getting ready to say, Alex, is Dr. McCullough's been doing this maybe longer than some of the people on the panel have been around or alive, but I'm not so sure that's exactly true. Might be true. Anyway, Brad Adato, any other thoughts or anything?
What Alex said, that this was a great webinar. I'm thankful to be part of it. And like everything else, I'm glad organizations like y'all are putting out information. I think it's so vital for everyone out there to listen and develop those best practices, because as more and more states open up and or increase what you can do at your practices, the better planned, the better educated all the individuals are, the better off we'll do, so that we won't have, hopefully, a large outbreak. Because honestly, the medical community, that's the front line as to who should be doing this right and demonstrating to everyone else how you can be doing it better than anyone else, and hopefully the other industries will follow.
Are you still with us, Dr. Drulis? Tony Drulis? He may have dropped off.
No, I'm here.
Okay,
Hello?
Tony. Yeah, we hear you.
Yeah, my only final word is everybody has given us a lot of good advice, and I think it's been an excellent webinar, and thank you very much for pulling it together, Randy. As usual, your organization is to be commended, and I think it's terrific, and it's very informative to help us all, because we're all trying to muddle through this quagmire.
Again, referring back to that excellent 61-page protocol document, I just think that I keep referring to that because I think it's a compendium, and sort of like compendiums are great, and then it has these little summaries. So it's a compendium, plus there's the Cliff's Notes part of it that you can get the quick view of everything, because it summarizes every one of the 7 categories that it gets into, and I think that's really important. A great resource too, the Aesthetic Authority allowed me to suggest to them that we would have a Facebook discussion site. And we have over 100 of us on there, I believe, and it's under the Aesthetic Authority Facebook site, but it's called the coronavirus and the private practice. I think that's the title of it. We've been interacting with each other for a couple of months on there, and I've gotten lots of great information. That's where I first heard about a lot of the congressional things that came to pass, and the loan and forgiveness and all those types of things. We've all learned from each other on that, and we're still learning from each other. And I think as colleagues, that's still the best way to do it. We can go to attorneys and we can talk to them, but talking to colleagues is always great. And I've really enjoyed the interaction. That's the one thing about working from home in that first 6 to 8 weeks. I communicated a lot with colleagues. We also have a meeting in November 5th through 8th. God willing, that may be one of the first meetings where we can all get together again. It's called Global Aesthetics Conference. And actually everybody on this call and everybody on the first 2 webinars, by coincidence, it wasn't totally by coincidence, but is part of that meeting or has been on the faculty or will be on the faculty of that meeting in November. And we're going to be discussing all of this stuff. But now I think we'll be able to see sort of a different view of things 6 months from now, and how right were we on everything that we said, and then what do we do over the next 6 months. So I think it's going to be an important time to get together, and again, God willing, we're planning on that meeting right now, and we hope to see lots of you there. And then a special thanks to the Aesthetic Authority. I'm honored to be the medical editor of that publication, but they've responded to really everything that I wanted to do. And some of you that know me know that I'm always kind of trying to think of things to do that can help colleagues and allows us to interact in a multi-specialty manner. And again, that multi-specialty word has always been something that I think is important. And the Aesthetic Authority has allowed that, encouraged that. And its sister publications, Dermatology Times, Ophthalmology Times, and Medical Economics have been equally supportive. And so we're going to be carrying these webinars every couple of weeks. We're going in 2 weeks. Our next one will be, we're going to get together with industry executives, and we're going to talk to the industry executives about some of the things that they're dealing with, and about how we can work with industry going forward, or how they can work with us, how we can work with them. I think it's going to be a very important webinar. I did promise Alex to ask one final question. I'm going to ask this to you, but I had somebody texted me while we were sitting here and said that they're a pharmaceutical rep. They're a good friend, and we love our pharmaceutical reps. They're really an important part of our practice in many cases, and they keep us supplied with things. They keep us informed. But now we're kind of keeping people out of the office. We're making it tough for people to come in. We're doing social distancing. How can they still do their job?
Oh, they'll be fine. No, I mean, they will, but I would, especially right now, I would be awfully cautious about who I'm allowing to come in the office at this point. FaceTime, when we're doing works, we're all getting very accustomed to working from home. I would be ultra cautious about that, because again, you don't know where that person's been. And I'll tell you what, if we all love our pharmacy reps, if they come into your office, they've probably been in someone else's office. And if they've been in someone else's office, they've probably been in someone else's office. So I think right now we're going to have to deal with remote communication. If we can do it by telehealth, we can do it with the pharma reps. It's just my thought.
More luncheons for a while?
Yeah.
Oh my God.
They're going to be fine. They will be okay. They will survive. I'm pretty sure they'll survive.
All right. Well, listen, it's been a great panel, everyone, and we've actually gone over time about 10 minutes, but we had a lot of really great questions, and the rep that asked me that question will be very pleased that I finished everything off with that. So I appreciate everybody getting on tonight, encouraging anyone to contact me directly if you're interested in the meeting or in the publication or learning anything more. Also, Aesthetic, A-U-T-H, Aesthetic Authority, they sort of cut it off there, Aesthetic, A-U-T-H @gmail.com. Lots of information there. Some of you have asked questions that we haven't gotten to that just came in, and we'll try to answer a lot of those questions, offline, and hopefully that'll work out fine. So anyway, thanks for everybody for listening in. Again, 2 weeks from now on a Tuesday night at 7 o'clock, we're going to have some of the top industry executives from both the laser companies and technology companies and injectable companies that will join us and kind of give their take on where everything currently stands and where we're going, what they're predicting for the rest of the year, and how we can work together with them to try to get through all this. But again, working with our colleagues, working with industry, working with our attorneys or our friends through sessions like tonight, I think that's where the next few months have to go. So everybody stay healthy, and hopefully everybody will join in 2 weeks from tonight. Thanks.
Thank you.
Thank you.
Thank you.
Thank you.
Not everyone.
Night.